Sandwich in between Sam and Robert's pretty tough, but he will get me adjusted. I'm going to do two things. I'm going to speed date with you. Do you remember back into the late 90s and early 2000s, we had things called speed dating, and you sat down and you talked to someone for 5 minutes as fast as you could, and then you met someone else. And this format reminds me of that, but it kindles so much discussion. So I'm going to spend 4 minutes with you in what we've been doing at University of Florida. And then what I want to do is a patient-centric presentation, and you'll have to all be patients to see this because it's from the patient perspective. But if we look at what we've been doing under Mark Gould's auspices, is looking basically at a Living with Food program. That Living with Food program has 3 aspects. It has a metabolic aspect, it has a food addictive aspect, and then it has a psychological dimension to it. What's curious is in terms of macronutrients, and as soon as Robert gets on, and he's the expert on macronutrients analysis, but basically work with our dietitians to encourage a lower carbohydrate, higher protein, and then backfill with non-trans fatty acids. And it works fairly well if you have the right dietitian. So that metabolic issue is very important. Second is food addiction model. And by using Mark's food addiction models, it's like an epiphany with the patients. They feel incredibly comfortable now in sort of a fellowship program. We also work with them on models of, obviously, of binge eating. We look at withdrawal issues. We look at queuing and fast, and then we look at, obviously, with craving. So that is a really neat environment and segue to introduce creative pharmacology in terms of obesity. And the last we look is the psychological dimension. I was at the University of Chicago, and it's heavily influenced with Chomsky's work. And so what we looked at was neurolinguistic substrates and how patients began to use creative language to develop their default position. We called those rooms. And it developed a little game called the flow game. It can be used in about 15 or 20 minutes. Sherry has actually played the game. She's still alive as of yesterday, so it's not a lethal game. But what it allows the patient to see is cognitively, where do they go in a default position? We teach that there are 5 domains, and we teach all the rooms all the time. We call them rooms, and that's where we are able to use that psychological dimension. So we compress these now. What we have is a psychological, food addictive model, and then macronutrient, and that really works very well. And how it works well, too, is with our dietitians, our bariatric physicians, and the psychologists. So that's your 4 minutes on speed dating. And I'm going to go from, I want you all to, right now, think of yourself as patients. So with our previous presentation, 70% of you are overweight or obese, so you'll make good patients? I'm just kidding, I'm just kidding. So this is from the patient perspective. And if we... When all else fails, go with advance, right? That's okay. Oh, beautiful. Globesity is something that I think, as a transcultural anthropologist, is obviously a very important issue. The term was first used by the World Health Organization in about 2001. It's obviously a blend with global and obesity. WHO claims that there, as of 2005, kind of a dated statistic, there are 400 million worldwide obese, with 700 million by tomorrow or next year. When you look at World Health Organization idea about that, actually, globesity is a worse epidemic than cigarette smoking. And when you add to that dimension what weight does to the metabolic syndromic issue, you begin to use the fusion term of diabesity. So obviously, obesity is globesity is a premier problem. BMI is traditionally used. Unfortunately, if you look at adolescents, many times they may show a decline in BMI, but the waist-to-hip ratios are actually increasing. So it's not necessarily a great issue for central adiposity, but it's a convenient tool. And then when we look at BMI of greater than 30 for obesity, and then we look at major killer diseases. So when we look at obesity, it's a major contributor to all these following diseases, which we've already outlined. Diabetes, stroke, heart disease, liver. We just talked about fatty acid intrusions and fatty liver disease. Certain cancers, endometrial, breast, prostate, and colon. Sleep apnea we've already spoken about. Now, again, from a patient perspective, if we look at worldwide prevalence of obesity, number of cases per given time period, it's doubled between 1980 and 2008. Some 10% of men and 14% of women as of 2008. 2008 is unfortunately, a lot of the statistics need to be updated from that time. In the US, 70% of individuals are classified as overweight or obese, versus 25% overweight just 40 years ago. So you can see sort of the inertial points. When you look at DALYs for overweight, they exceed that you would find in smoking. More than a third of the US citizens are born obese. Medical costs are somewhat $1,500 more per year. If you look at the demographics, non-Hispanic blacks, highest obesity, about 49%. This is CDC data. Mexican Americans at 40%, and non-Hispanic whites at 39%. There doesn't seem to be any correlation between education in males and obesity, but in women, those of higher education have a trend towards less obesity. And in 2008, this is an old figure, we keep using it, it's about 150 billion per year. Worldwide, when we began to look at globesity and look at its prevalence, 22 million under age 5 are obese, 1 out of 10 of children are overweight. In developing countries, it's very interesting, there's an inversion with developed countries. So in countries at higher income are more obese in developing countries, we get the inversion of that. Worldwide urbanization, fast food, oversized high-carb beverages, increased television time, sedentary lifestyles, they all contribute to higher adolescent obesity. And this is an alarming figure, that obesity that persists into childhood is higher among obese adolescents. And some studies are suggesting as much as 80% of current overweight adolescents will go on to declare themselves as obese in childhood. If you look at the NHANES data, of course they've just reported more recently than this, but this is a report by Yanofsky et al. And what they found was that there is, in obesity in women, it's about 35%, and in children between 12 and 19 years of age, 32%, and we may be seeing some stabilization over the last 10 years. If you look at NHANES data with males, it's about 32%. The caveat in all this, if you look at morbidly obese males, adolescent males, there's actually an increase in all NHANES report. So there's growing evidence right now that obviously children are now contracting formerly adult diseases from hypertension, fatty liver disease, as well as diabetes. So there's a trend towards stabilization of obesity. Even these authors say the numbers are quite small. If you look at the latest NHANES, they're down to 800. So there's some questions of stability as to whether there really is stabilization. Some studies argue that men entering adult life obese have twice the mortality as those who do not. WHO is pointing, these are really problematic populations, African and Latin American populations. That's where we have the highest obesity rates. WHO figures a third of adults worldwide obese, 1 in 10 are overweight, and 1 in 10 are obese. So even if obesity rates are stabilizing in high-income nations, we know the rest of the nations are having a rapid ascension of their rates of obesity. So how do we contain obesity? Well, first of all, you need to focus, obviously, on child and adolescent. This is where you're going to get the main bang for your buck. Increased involvement of family and community. We've already talked about this. And then it's very important to engage patients very early on in exercise. And you're doing this principally for lipoprotein lipase and GLUT4 receptivity. So as I like to say to our patients, you're not going to lose weight by exercising, but you're not going to lose weight unless you do. And then I think it's we have to understand the unique vulnerabilities of adolescents and addictions. It's felt that during adolescence, they have about a 40% increased chance of contracting an addiction. So these are all unique aspects of adolescent medicine. So in summary, obesity appears to have the same or greater impact on global health as cigarette smoking. It is the greatest contributor to type 2 diabetes, which now obesity has overtaken malaria and AIDS worldwide as the #1 killer. If we look at the treatment of children and adolescents, it's obviously going to be the key to defeating obesity over time, and implementation of modern advances, including food addictions, we hope, will help to make a dent on this epidemic. that's it, folks. I don't know if I got in.
30 seconds.
That's not bad.